is that from the discovery of the EGFR mutation in 2004, and we have the result of our IPASS study about 2009. We have been using so many EGFR inhibitors for almost 20 years, but we still discussing the best initial treatment and the sequential treatment strategies. With a few studies, some of the studies you've been shared with us, do you think we have found the best solution so far? And what kind of patient actually in your clinical practice will you choose this strategy? You know that sometimes we've learned the results of the RCT study, but there is another story in our clinical practice. We have so many situations to choose. Like you do mention the age for younger population or elderly population. For this kind of population, what kind of treatment do you think is the best one? Thank you.
So last question. Yes, I don't use the Mariposa in first line because I am scared about the toxicity. So, but if the Mariposa will be positive for the overall survival and not the FLAURA2, I think we should think about the Mariposa. So what I do in general, I use the combination of the FLAURA2 only in, first of all, I discuss with the patients because some patients don't want to have the toxicity of the chemotherapy. And so if they don't want to have the toxicity of the chemotherapy, I go with Osimertinib alone and I continue maybe with chemotherapy combined with Amivantamab in the second line. For example, if I look, I use the ctDNA because if you look at the results of the ctDNA negative population, the progression-free survival of Osimertinib alone is 3 years. So why should we give chemotherapy in these patients for 3 years that with Osimertinib alone, they do so well? So I don't propose the combination to these patients if they don't shed the DNA. I always propose the FLAURA2 100% cases in patients with brain metastasis. And I propose the combination of FLAURA2 in all patients who have a big burden of disease. Because also if the response rate is very high also with Osimertinib alone, there are some patients who do not respond to the Osimertinib alone, or at least the tumor remains stable. So if you want to shrink the tumor quickly, I prefer to use a combination. And what we discuss sometimes is, should we continue after 4 cycles of chemotherapy, should we continue pemetrexed forever in these patients? So sometimes you see that there is a decrease of the renal function when you do pemetrexed for a long time. And so sometimes I do, I check the renal function and sometimes I stop pemetrexed and I just continue with Osimertinib alone. So I think that there is also a big room of personalization of these treatments.